professor of pediatrics there, and bilingual in Spanish and English. And I look forward to hearing our talk. So, Carrie.
Thank you very much for the invitation to present here today, and I know many of you from McKay-Dee Hospital, and today I'm going to talk about our febrile infant protocol, particularly with an emphasis on fever in infants 1 to 90 days of age. And I wanted to just point out on the slides, if I can get this to work, this little logo here, which is the symbol of the American Board of Pediatrics. And the evidence-based care process model that we're going to be talking about was approved by the American Board of Pediatrics in January of this year for maintenance of certification. So this is a care process model that can be used to demonstrate proficiency in quality improvement if you need to do that to renew your boards. And everyone whose boards expire after January 1st, 2009 needs to show that competency. So I'm going to talk about that just a little bit and how you might be able to use this for the boards. But we were very, very excited about this designation. There are only 8 protocols in the United States that have been approved so far, and this is one of them. So we're very pleased with that. This is the reason I think I'm in pediatrics and that I study research, or that I study and that I perform research. I love infants. I think they're just fantastic. And if you practice pediatrics as I do, you know that the question of fever in the early infant period is a very vexing question. And it was one of the first questions I was posed with as a medical student, and it has just stayed with me as this persistent problem. And over the time that I've been in Utah, I've had an opportunity to study it. And so looking at these infants, if all we know is their age, and we know all of them are under 90 days of age, and the only other fact that we know is that they have a temperature of at least 38 degrees, we know that one of these babies will have a serious bacterial infection. And a serious bacterial infection could be a urinary tract infection, bacteremia, or meningitis, all of which are life-threatening in this age group. And I use this slide when I am meeting with my residents to really point out that we can't tell by looking. It could be any one of these babies, and we just absolutely cannot tell by looking. And I like to tell the story of one particular child from early in my practice, really very much in the first year that I arrived here in Utah and was seeing in my own clinic. And this was a baby who came in for a 2-week well child examination. Mother thought everything was great. I thought everything was great. The child looked fantastic. And the nurse came to me and said, "But doctor, his temperature was 100.4. And for those of you who practice pediatrics, you just know the groan that I had in the room. I was like, no, why did you take the temperature? That's not part of our protocol for well child checks. And so I went back and forth, and spent a lot of time explaining to the mother why we had to send her perfectly well-appearing infant to the hospital and to do blood and urine cultures and obtain a lumbar puncture. And I felt so guilty about it. Well, I did do all of those things, sent the baby to the emergency room, admitted the baby. And within 12 hours, both his blood and his spinal fluid cultures were growing E. coli. And this is a lesson that I will never, ever forget. And anyone who's practiced long enough has a story like this. That infant started antibiotic therapy probably within an hour to 2 hours of when he developed meningitis. And he's still my patient, and I'm happy to say that now at age 12, he is attending special school, but he's attending a special school for smart kids. And that has been a very gratifying outcome for that infant. And I think it points to the fact that you cannot tell by looking, and that any fever in this age has to be taken very, very seriously. It is very difficult for infants to mount a fever to an infectious response. Their immune systems are pretty immature, and if they are showing you that they have a temperature, even just one time, we have to take it seriously. And the vast majority of febrile infants who have serious bacterial infection only have a temperature one time. And so that 100.4 is important. So as you know, fever in infants 1 to 90 days is very common. And at Primary Children's, where I practice routinely, 58% of our ER visits in infants 1 to 90 days of age are for the evaluation of fever. And it trumps everything else that comes into the emergency room at this age. And as I've said before, even a single temperature of 38 degrees or 100.4 is associated with bacteremia, meningitis, and urinary tract infection. And I forgot to say on the picture, I think with the infants, one of those babies will have SBI, but we just don't know which one. So today I want to help you understand some of the objective findings that can be associated with serious bacterial infection and that can help us stratify an infant's risk. I'll spend a little bit of time at the very end talking about pathogens that cause serious bacterial infection and why we have the antibiotics in our care process model that we do. And then I want to spend a fair amount of time talking about the Intermountain Care Process Model. If you all are local physicians, many of you probably admit children to McKay-Dee Hospital, and the Intermountain Care Process Model for febrile infants is active at McKay-Dee Hospital and available on all of the computer terminals throughout the hospital. So as I've said, I've studied the febrile infant since I arrived in Utah, so that was in 1995. And I've been able to do a lot of things at Primary Children's and at Intermountain Healthcare that can't be done other places because of the robust electronic medical records that we have through the Intermountain Healthcare system. So that's been a real advantage in trying to do research. And I think the other advantage is just the collegial nature of the environment where we practice, and physicians want to help and be part of the research. So do the laboratory staff, and parents are interested in participating in research, so that's been very helpful. So of the things that I've been able to do and that I'm going to share with you, the first is a reanalysis of the Rochester criteria. And as you know, the Rochester criteria were published in the 80s as a way of identifying infants at high risk for serious bacterial infection. And so I've been able to reanalyze that here in Utah. I've been able to look at age and also viral status as factors related to serious bacterial infection. And then I'm going to share with you some data that's pretty recent on looking at complete blood counts and urinalysis, so CBC and UA, as simple predictors of serious bacterial infection. And then talk to you about the kids that we all fear, the ones we miss. So missed serious bacterial infection and how we can avoid that. I think that's the one thing we fear the most, like when I think back about my own infant that I admitted rather than sent home, I often think, what if I had sent that baby home and said the 100.4 was just a spurious result, maybe a result of bundling? What would have been his outcome today if I had sent him home and diagnosed meningitis the next day? And so, I'm going to talk a little bit about missed SBI. So all of the studies that I'm going to talk about were done within the state of Utah. The studies from 1996 to 2002 were done prospectively. That means I had someone positioned in the emergency room at Primary Children's essentially 24/7. Very expensive way to do studies, but very accurate way to do studies. And then from 2002 to the present, I've learned how to use the electronic medical records of Intermountain, and that's been very satisfying and allowed us to enroll lots and lots of kids. So the prospective studies, in 6 years I enrolled almost 1,800 children, and now using the electronic medical records, every year I'm able to enroll 2,000 children, and it's at a much lower cost, so I can answer a lot more questions that way. So the first thing I talked about was the reappraisal of the Rochester criteria. And as you all may know, the Rochester criteria contains 15 or 16 different elements depending on whether you have diarrhea or if you have a chest x-ray. And these elements are difficult to remember somewhat confusing. And the reason that there are so many elements to the Rochester criteria is that their original publication only had 233 infants. And so they couldn't narrow down those factors any more than that. They could just say these 15 or 16 factors are associated with serious bacterial infection. And it worked well in Rochester with a good sensitivity. That means it picked up almost 96% of the kids it should. And if it was negative, the chance of having a serious bacterial infection was almost nothing. You know, it was 99.3% of low-risk kids really did not have serious bacterial infection. So it worked well. When we repeated it in Salt Lake, unfortunately, it did not work as well. So not as sensitive and not as specific for infants with serious bacterial infection. This is not unexpected when you develop a methodology in one location and test it in another location. It often does not work as well. So that was the bad news. But the good news, and I think this is really good news, is that we had a large enough number of infants that we could actually look at individual criteria, each of the individual 16 Rochester criteria, to see if there were any criteria actually statistically associated by themselves with serious bacterial infection. And this is what I teach my residents. We now call this the modified Rochester criteria, and there are only 4. And for those of you who are in practice, it's a lot easier to remember 16 things than 4 things. A lot easier to remember 4 things than 16 things. And the good news is that these 4 things are 4 things that we can get in virtually any setting that has a simple laboratory. So the first one is to have an abnormal urinalysis with greater than 10 white blood cells per high power field. The odds of having a serious bacterial infection are staggeringly high. So you're 38, almost 39 times more likely to have a serious bacterial infection if you have this than if you don't. And people say, well, that makes sense. They have urinary tract infections. But also we see a lot of kids with bacteremia who become dehydrated and their urines are concentrated, and we see this finding. If you have an abnormal band count or white blood cell count, both of those are also statistically associated with serious bacterial infection. And virtually any laboratory, certainly any laboratory associated with a hospital setting, can obtain a CBC and a urinalysis and give you results usually in under 1 hour. So I found that to be very good news. The other good news piece is that the history of chronic illness and prematurity were also highly associated with serious bacterial infection, almost tenfold more likely to result in serious bacterial infection. Well, anyone who's seeing the baby will know if there is a serious chronic illness. Think about the types of illnesses that present in the first 90 days. You have to have something serious enough that you've been able to diagnose it in the first 90 days. So that's usually a major congenital malformation, a major chromosomal problem, or a known immunodeficiency like HIV or malignancy. These are serious conditions, and we as healthcare providers will know that history. And then we can know their prematurity history as well. And by prematurity, I mean that they were born prior to completing 37 weeks gestation. And so those are things that are easy for us to elicit in the history taking. So these modified Rochester criteria are what I teach my residents to ask in the emergency room and to look for. Yes, I see a question. The preferred method actually is a catheterized urine specimen. So the question was, how do we obtain the urinalysis? And so I find that almost no one knows how to do suprapubic aspirations anymore, though that's a fantastic way to get urine. And if you're able to do that, that's a perfectly acceptable specimen. Catheterized urine specimens are what we teach in Intermountain to do. But I always do tell people, if you are prepping a baby to get a catheterized urine specimen, always have an open urine cup right there, because as soon as you're doing the betadine, they're going to let go, and you can get a midstream too. I prefer not to get bagged urines, though. So anyway, this is what I teach my residents to know, and to remember these 4 factors in the emergency setting or in their office setting. The other thing that I looked at was age, and found that if infants were classified as high risk by the 4 modified Rochester criteria, and they were older than 28 days, so 29 to 90 days, they were less likely to have a serious bacterial infection. And I think this really goes to justify our practice, which is to treat infants in the first month of life more aggressively than we treat infants in the second 2 months of life. And at Primary Children's, about 99.9% of infants younger than 28 days are admitted to the hospital with fever, whereas only 50% of infants who are 29 to 90 days of age are admitted to the hospital with fever. And these statistics actually kind of validate our clinical practice. And then finally, I looked at viral infection and found if you had a laboratory-confirmed viral infection, you were much less likely to have serious bacterial infection, about 70% less likely to have serious bacterial infection. And when all of the criteria for the evaluation of the febrile infant were published in the late 80s and 90s, it wasn't really possible for us to diagnose viral infections very quickly. You might get a result back in 9 or 10 days, and that certainly was not going to be helpful in the acute setting. That's changing and has changed dramatically in the last 10 years, and it's accelerating in the last 5 years. And I believe, and can talk about some technology later if there are questions, that we'll be able to diagnose most viruses within an hour in the next 2 to 3 years. So this is changing very quickly, and it is important to know that infants with laboratory-confirmed viruses are less likely to have serious bacterial infection. So the take-home from this is that if you take those 4 criteria, which I call the modified Rochester criteria, and you add age and their viral status, we're now able to reach a sensitivity very close to what was originally reported for Rochester. And so these 4 criteria plus age and viral testing is acting very much like Rochester was in the past. And I put it all together because I think it's easier sometimes to look at it this way rather than odds ratios into a stoplight configuration with green light, yellow light, and red light babies. So green light babies, those at the lowest risk of having a serious bacterial infection, are those that have no modified Rochester criteria positive. That means they had a normal CBC, a normal UA, they have no chronic illness, and they were not born prematurely. And then if they're older than 29 days and they have a virus, less than 1% of them will have a serious bacterial infection. This contrasts with the yellow light babies who have a positive on the modified Rochester criteria, but they also have a virus. And these babies have a risk of serious bacterial infection somewhere between 4 and 6%. And I now have a larger data set than what this was developed on that says that number is really about 5%. And that 5% is consistent across the different viruses that we may see. And although 5% is more than 1%, I think we would all agree it's significantly less than the red light babies. These are babies who are high risk on the modified Rochester criteria and have no virus identified. Between 1 in 5 and 1 in 3 of these infants will have a serious bacterial infection. And I hope that this kind of stratification would be useful to you in the clinical setting. To me, it's clear that if you're a green light baby, it's safer for you to be at home than to be in the hospital. And that these are babies that are safer to be managed without antibiotics than with antibiotics. If you're a red light baby, it's absolutely clear you need to be in the hospital. And these babies need to be in the hospital and need to be receiving antibiotics until we have the results of their culture testing. And then this yellow area is ripe for study of what is the right way to manage these, especially when we can get something like a rapid RSV in the emergency room. And so these are questions that I'm studying now, is what is the best way to manage this group. But I think it's clear for green and red light babies, outpatient, inpatient. I saw a question, yes? So to me, you quickly decide if a child has a virus by doing specific laboratory testing. Right now, we have laboratory testing at Primary Children's and within Intermountain that can give you the results of viral testing between 4 hours and 20 hours. So that is helpful in an admitted infant, but not necessarily so helpful in the outpatient setting. There's no common testing for all of them? And I'm going to tell you the testing that's available now that we do, but I actually have worked with a company, a small company in Salt Lake called Idaho Technology, and we've developed a platform that is going for FDA trials starting in November at Primary Children's that tests for 18 different viruses and all bacteria at one time. And the result is available in about 55 minutes. We're trying to get it to 45 minutes, but it's available in about 55 minutes. That kind of technology, which uses the polymerase chain reaction and can be done in any clinical lab, will revolutionize the way we identify these infants. And that's coming in the very near horizon. Rapid RSV testing exists now, and I will just mention that rapid RSV testing can give you a result somewhere between 15 minutes and 30 minutes, depending on the platform that you're using, and is available in most of the emergency rooms and works well. And I want to contrast that to rapid flu testing, which also will give you a result within 15 minutes to 30 minutes, but does not work well, particularly in the febrile infant. And I just want to mention that we're in the midst of H1N1 flu. You've already heard the swine flu talks in your lecture series. I absolutely do not recommend the rapid flu kits for febrile infants and for young infants, because you're just as likely to get a positive as a negative. The sensitivity, specificity, you might as well flip a coin. And I think if you get a positive and it's a false positive, you could make a dangerous decision for the infant. I see a question back there. They get to stop at the UA and the CBC, and I'll go through that protocol a little more detail in just a few more slides. Yes? Not the CBC by itself. The only way you can really say it is a virus is to do a diagnostic test. And of all the viruses that we can test for easily now, RSV and influenza A have the lowest risk of a secondary bacterial infection. And so actually being able to put a name on that virus, I think, is important, rather than just saying it's bronchiolitis, because bronchiolitis can be caused by many different viruses. And just to show you the difference, a baby with influenza A has a chance of having a secondary bacterial infection of about 1%. An infant with influenza B is about 9%. It's really different. And so putting the name on that virus is important, because the clinical syndrome for both of those is going to look exactly the same. Mm-hmm. No, I'm going to show you what we're going to do for viral testing in just a second. So our conclusions from the 10 or 11 years of work that we had at Primary Children's is that the minimum evaluation a febrile infant should have in order to determine their risk status is their age, their history of chronic illness and prematurity, and a CBC and UA. That's the minimum that any baby should have, and we believe that all babies should have that. The viral studies are very important as well, and further help you decide who is most at risk and least at risk for serious bacterial infection. This is what we recommend currently for viral testing, and this is what is readily available in all Intermountain facilities. The first one is a viral respiratory direct fluorescent assay, DFA assay. That's done with a nasal wash, and it tests for 8 different viruses at once. These are respiratory viruses. It tests for adenovirus, influenza A and B, parainfluenza 1, 2, and 3, respiratory syncytial virus, which is RSV, and human metapneumovirus. We recommend that this test, which is very easy to perform, inexpensive, it costs $35.11 at Intermountain facilities, be done year-round, because many of these viruses circulate year-round, particularly parainfluenza and adenovirus. They're not just winter respiratory viruses. The second test that we recommend is Enterovirus Pcr of blood and or CSF, or both preferably. And that should be done during the months of June to November. Enteroviruses are actually the most common cause of fever in the first 90 days of age, and they are responsible for 25% of all rule-out sepsis evaluations year-round and 50% during the months of June to November. And so if you only can do one test, I'd say do the viral respiratory DFA. It's easy, it's inexpensive. You get your answer usually within about 4 to 6 hours. And then the enteroviral PCR test, for those of you who practice in Intermountain facilities, you would send that to the Intermountain Central Laboratory. And there is a courier schedule, and usually these results are being reported in 12 to 18 hours. And it's particularly helpful if you have an admitted infant that you're now trying to decide to send home after 24 hours, which we'll talk about in just a moment. Are there questions about the viral testing? So the viral respiratory DFA, it's a direct fluorescent assay. It uses fluorescent labeling to identify virus in nasal mucus samples. And it tests for 8 respiratory viruses at one time. Yes? Certainly. DFA technology is less sensitive than PCR technology. And sometimes that's to our advantage, and sometimes it's not. So PCR technology is always going to perform better as far as identifying positives. What we don't know about PCR technology, and what we're studying right now, is how long does that PCR stay positive. And we think for some things like rhinovirus, you may get a positive PCR for 6 or 8 weeks. And so sometimes PCR is just too sensitive, where you might pick up something that might not be actually the cause. DFA is less sensitive, so you really need to be having active viral shedding, and a positive DFA is usually associated with the cause of the illness that you're seeing. And for RSV, which is perhaps the most common viral disease that we see year in and year out, that we test for by DFA, RSV is almost as sensitive by DFA as it is by PCR. So if you have a DFA negative for RSV, they probably don't have RSV. It's a very, very good test for RSV. Now I'd like to talk a little bit about the CBC and urinalysis and why I think that's important for helping us not miss serious bacterial infection. So this was a database query, and I looked at 5 years worth of data, electronic records at Intermountain all throughout the state of Utah. I gathered their CBC and urinalysis result, and I used those results to say if the baby was high risk for SBI based on the modified Rochester criteria, low risk, or if I did not have enough information to determine the risk, and we called that undetermined risk. So during this time period, there were 10,316 febrile infants evaluated in all Intermountain facilities. Half of them were admitted and half were discharged. And it is this discharge group that I'm particularly interested in. When we admit a baby, we take a lot of risk off of ourselves and off of the infant. They're under observation in a hospital setting. But when we discharge them home, we carry risk and the family carries risk. So this is the group that I'm really interested in. And when I looked at the infants who were discharged home from the emergency or urgent care setting, I found that 61% of them had a complete blood count, 54% had a urinalysis, and 49% had both. This was actually astonishing and somewhat devastating to our pediatric group and Intermountain. For 30 years, since 1971, so more than 30 years, it's been recommended that CBC and urinalysis be performed on febrile infants. And yet, at one of the most technologically advanced integrated healthcare systems, it was happening less than 50% of the time. It was a real wake-up call for us. When we started this quality improvement project, we really thought we were going to add on viral testing, and that's what we would be working towards. But when we did this analysis, we saw we had other work that needed to be done, which was really to get physicians to be ordering CBCs and urinalysis. Question? Yes? We recommend a rectal temperature for this age group. So then the other devastating piece of this was when I looked at the infants who were discharged, 10% of them were low risk, so of course perfectly appropriately discharged from the emergency room. 24% of them were high risk. That's a concern to us that almost a quarter of the discharged infants were classified as high risk for serious bacterial infection. We think that that can result in devastating outcomes such as missed serious bacterial infection, and I'll show you some of those results. But then a huge chunk, almost 2/3, were undetermined risk. And usually what that meant is they had a CBC or a UA, but not both. And when you are evaluating someone in an emergency room and you can get these results back in an hour, it was kind of staggering to us that they wouldn't be done in order to try to inform who you were going to admit and discharge. And so these were two areas that we were really working hard on in Intermountain. And of those infants who were discharged home, 63 of them came back within 3 days and required a hospital admission. So that was 1.2%. And you might say to yourself, and I agree with you, well, gosh, we did pretty well. You know, 98.8% stayed at home. And they did. And we were lucky. And they stayed at home probably because they really were low-risk infants. But the ones that bounced back with serious things, including 5 who bounced back with meningitis, our biggest fear. And these 5 infants do have ongoing long-term neurologic complications. To do a CBC and a urinalysis costs about $60 for febrile infants. And so you can do thousands and thousands of CBCs and urinalysis for one missed case of bacterial meningitis. And so the lifetime cost of a missed case of bacterial meningitis is in the millions of dollars for long-term health costs. And then, so meningitis was the most common bounce back, and then bacteremia. These are absolutely life-threatening in this age group, and we were fortunate in this 5-year period that no infant died from missed serious bacterial infection, but we have seen that certainly within Intermountain at other times. And when we looked closely at who bounced back, it was predictable. The high-risk infants bounced back. So they were more than 2 times more likely to be readmitted for any reason within 3 days, and almost 2.5 times more likely to be readmitted for missed serious bacterial infection. And missed serious bacterial infection was the most common reason to be readmitted. So usually what that meant is that they had had a blood culture and a CSF profile done in the emergency setting and sent home, and then those cultures became positive. And sometimes it meant that they didn't have those done, and the child became sicker and sicker. We had one infant who came back to the emergency room 4 times before they were admitted. And that was amazing as well. If you have a febrile infant and you do discharge them and they come back once, you better put them back in the hospital, because that's a risky situation. So we concluded the majority of our outpatients were not getting what they needed for simple laboratory tests, and that obtaining these tests would help you identify high-risk infants. And it is our belief that high-risk infants are more appropriately managed in the inpatient setting than in the outpatient setting. And some of you will say, well, gosh, I don't want to admit every high-risk infant and have them sit in the hospital for 3 or 4 days. That's not what I'm advocating, and I'm going to talk about our early discharge protocols as well. So this is what we're doing in Intermountain facilities throughout Utah. we identified 6 key points for quality measures, and we call it an evidence-based care process model. And our 6 core measures are that every infant receive core laboratory testing, and that means a CBC and a urinalysis. Those infants who are going to be admitted would receive viral diagnostic testing. We would admit all high-risk infants. We would give appropriate antibiotics. We would stop antibiotics within 36 hours and usually by 24 hours for febrile infants who have negative bacterial cultures, and that we would aim to keep our length of stay less than 42 hours. Eventually, we'd like to get our length of stay down to 24 hours, but we have to work in a stepwise methodology. And I didn't have any time to show you my antibiotic data, but we found that febrile infants through Intermountain were getting 29 different antibiotic combinations, including fluoroquinolones, vancomycin, linezolid, drugs that are absolutely not indicated in this population. And so we wanted to have a way to kind of control that also. So the evidence-based care process model has many steps, and I'm going to just go through. This is the emergency room, and it has history and physical that you obtain and check boxes. If in the history or physical you identify chronic illness or prematurity, you come into this high-risk group where you would do lab testing, and it tells you what labs you would get. The limited labs include CBC and urinalysis. Once you have your lab results, then you're either designated a high-risk infant or a low-risk infant. The recommendation for high-risk infants is that you admit them and treat them with antibiotics. The recommendation for low-risk infants, you can either discharge them home or admit them, depending on the social situation, your comfort with the situation, your clinical judgment, and you can treat them either with or without antibiotics, again, depending on your comfort. The caveat, though, is if you are going to give IV antibiotics or oral antibiotics, we highly recommend that you get the lumbar puncture to complete the sepsis evaluation prior to giving antibiotics. We have many, many cases, and it's a whole nother study, of infants who got a CBC and a urinalysis, got a nice shot of ceftriaxone, went home, had a urinary tract infection identified or had a bacteremia identified, and now is back. They still have fever, they get the lumbar puncture, and they have 22 white cells on the spinal fluid, or they have 40 white cells on the spinal fluid. That is going to be called partially treated bacterial meningitis most of the time, and there's no way to figure out whether it was viral or bacterial. I can't fix it, you can't fix it, no one can fix it, and those infants end up getting PICC lines and IV antibiotics sometimes for 21 days. And so it really, if you're going to give the antibiotics, then you should get the spinal fluid prior to getting the antibiotics, if at all possible. If the infant's not in shock, you should at least make the attempt. Once they come into the hospital, we have an admission algorithm that again says the first step is to make sure, did they have the right lab sent, and do you know if they're high risk or low risk? And if you do, then you have a high-risk algorithm that talks about what you're supposed to do and a low-risk algorithm, and it gives the estimated times for discharge. And for infants who are low risk and they have a negative bacterial cultures at 24 hours, we recommend that they go home at 24 hours. And if they can't go home because they can't eat or they need oxygen or suctioning, that their antibiotics be discontinued. The same would be true for an infant that classified as high risk but was now found to have a virus. If they're negative at 24 hours on bacterial cultures and they have a virus, the likelihood that they will have a bacterial infection diagnosed in the second 24 hours is less than 0.05%. So we would recommend that in any case they have their antibiotics discontinued, and if at all possible, that they would have a hospital discharge. And then high-risk infants who test negative for virus, we recommend that they continue their antibiotics for 36 hours. We did an evaluation of 22,000 cultures in febrile infants and found no significant pathogens detected after 36 hours. And so 36 hours is really the longest time we're advocating for sepsis evaluation. And our goal is 100% of these infants will have these care quality measures in Intermountain Healthcare. And we have also included an order sheet, a standard order sheet that has the antibiotics dosing and regimens that we recommend. And these got a little compressed because I have a Macintosh, but I just want to show you how we're doing. So this was the 2-year period. These are called run charts. This is the proportion of infants getting the desired testing, and these are the months prior. So these were the 2 years prior to getting to starting our care process model, and this is the urinalysis. And we were at about 68% getting a urinalysis. This is the average here. We are now nearly 100% getting a urinalysis within the first year of starting our care process model. This is for the CBC and urinalysis. Again, we were at about 60-something%, and we're now at about 90% getting a CBC and urinalysis. And we monitor this every month, and we know that we're maintaining these rates. We monitor it by hospital, we monitor it for the total facility, and we can actually monitor it by physician for maintenance of certification. So if you wanted to participate in maintenance of certification and say, I am going to make it my goal to get a CBC and UA on each infant, we can monitor that for you and give you your quality measures. Our viral testing was also up. Our appropriate, there's our antibiotics. Our appropriate use of antibiotics was up, and our length of stay is coming down. You can see how the 4 major institutions within Intermountain that admit infants, Primary Children's, Dixie, McKay, and Utah Valley, had very wide variation in how long those infants stayed. And with the introduction of that care process model, we just see us all coming to a unified point. So I think I've presented a ton of data, and there might be more questions, and I don't know if my time's up. So I want to just allow time for questions, and thank you very much for your attention. Way in the back.
When you collected the data, did you get that temperature from a clinic or a ER temperature, or could that be the report of the parent?
It can be any of those, and there's actually good data to support if a parent can tell you an actual temperature, 100.8 or 38.1 or any actual temperature, that correlates very well with a measured temperature in a medical setting. So I will take parent report or any measured temperature. Yes?
We're not using urinalysis rather than the antibodies for high-power field. Does that correlate with a lot of urinalysis?
Using the dip like the nitrites and the leukocyte esterase? I'm working on that right now, and I think that I actually have enough. We've got 12,000 infants right now, and I think I'm going to have enough to actually answer that question. We do tend, if I see positive nitrites, I'm very concerned, and certainly positive leukocyte esterase, and my feeling is, and I think the data will support that that would be a positive. Yes, ma'am. So it could be adequate if your total white count was abnormal. So let's say your total white count was 17,000. Then you've identified a high-risk baby. Or 3,000. You've identified a high-risk baby. Where you're going to get into potentially some trouble and maybe miss someone is if you have a baby who has a white count of 14,000, but you don't know what their band count is. So you have more information, but I mean, you can try it with what you have locally and see if you feel that it's sufficient. Many times the lab will. At Primary Children's, the lab will. And so you'll want to talk to your local laboratory and see if they have been trained. And part of the care process model, we went and visited the 4 major Intermountain facilities, including McKay, and did extensive training on how to obtain a catheterized urine specimen. We found, for example, in Dixie, in St. George, only 19% of febrile infants were getting a urinalysis, and we couldn't understand why. And when we went to the emergency room, we found that all they had was adult Foley catheters. They didn't even have the equipment to do the test, and so there were things that we needed to correct, and nursing needed to be instructed to feel comfortable and to learn the techniques of obtaining a catheterized urine specimen. Yes, sir?
We're going to make a comment on standardized antibiotic.
Yes, and I've kind of breezed through that. Thank you for reminding me. So this is the bacterial epidemiology of febrile infants in our area. These are from Intermountain Healthcare data. And the most common pathogen by far is E. coli, 61%, 66% in 2005, and it's about the same now. And roughly 80% of our serious bacterial infections are due to gram-negative pathogens. That is distinctly different from the 70s and 80s when the most common pathogen was group B strep, a gram-positive pathogen. Now, about 80% are gram-negative. And the problem with that is, who can tell me the normal, what do you start for rule out sepsis? What were you taught? AMP and Gent, right? AMP and Gent. For some of you, it might have been AMP and chloramphenicol, but for most of you, AMP and Gent is what you were taught. And you could say it in your sleep. It's a knee-jerk. Here's the problem. Gram-negatives, which is most of our cases, in Utah, half of them are resistant to ampicillin. And we have published these data. When you're treating with AMP and Gent, and it's not a UTI, if it's bacteremia or meningitis, when you're treating with AMP and Gent, AMP is the killer and Gent is the helper. You cannot clear bacteremia or meningitis with Gent alone, with gentamicin alone. You need a killer drug. And if half of our gram-negatives are resistant to ampicillin, we really can't rely on AMP being the killer drug before you know what the cultures are. And so our standardized orders actually recommend, if you suspect bacterial meningitis, you include a 3rd-generation cephalosporin. And sometimes that means being on 3 antibiotics for the first 24 hours till you know what you have. And so we would recommend that if you suspect bacterial meningitis, or if you have an infant who's in shock and needs to be covered for both gram-negative and gram-positive. And so if you look at our 3rd-generation cephalosporin resistance, we're doing okay, but it is coming up. And gentamicin, we're doing fine. But again, gentamicin is a helper drug. You can treat a urinary tract infection with gentamicin alone, but you would never treat bacteremia or meningitis with gentamicin alone. So our standard order sets actually allow 4 antibiotics: ampicillin, gentamicin, cefotaxime, and ceftriaxone. And it tells you the correct doses and when you would use those. We also put on the dose for Tylenol because we saw frequent overdosage in this age group, and we put on the correct dosage for acyclovir because we saw frequent underdosing for acyclovir in this age group. So that's what our standard formulary says, and it tells you in the boxes what you would use. So those of you who have access at McKay or other Intermountain facilities, this is on the clinical programs website. Your charge nurses should know about where you can download these. The order sets are downloadable. You can print them out with holes or without holes, depending on how your charting is. And we think it makes it a lot easier to admit a febrile infant and to choose the right medications. Any other? It's the Intermountain Healthcare for-physician website, and if you go to the clinical programs and the pediatric section of that, you will see a whole thing on febrile infant, and there's just tons of material to download on febrile infant. And there's even set of slides that you can use to test your knowledge on the care process model. Yes? Yeah. Okay. And I would say less than 29 days. So 28 days or younger. Okay. Mm-hmm. Yes. And I'm sorry I didn't make that more explicit, but it is in the care process model. Being younger than 28 days by itself is considered a high risk factor. And so we would recommend admission of all infants under 28 days. Yes, sir.
As far as the clinic, if you clinically suspect an Enterovirus, but just using your objective criteria, so suspicious it's urinary infection, maybe the UA is abnormal, are you still, if you're going to use an antibiotic, you're going to do an LP?
Yes. Yes, I would. And that's because, particularly in the case of urinary tract infection, there is some evidence that urinary tract infection by itself results in elevated white count in the spinal fluid. And what can happen, and we know that most urinary tract infections are caused by gram-negative organism, what can happen is you think you're treating a urinary tract infection, and then the next day there's still fever, the baby looks worse, you do an LP, and you have 30 white cells. Now you have 30 white cells in your spinal fluid and a urinary tract infection from E. coli. You're stuck treating for E. coli meningitis. If you had done the LP before antibiotics and it was sterile, you would know that this was just a urinary tract infection. And I actually am a big believer in treating urinary tract infections the first day with IV antibiotics, but then if everything else is clear, to send them home on oral antibiotics. And I'd much rather do that than to put a line in and do 21 days of IV antibiotics at home. So, yes, sir. I was waiting. I almost didn't want to say acyclovir on the antibiotic thing because I knew it would come. That's an entirely whole nother hour lecture, but it's very important. And we are actually developing a care process model for herpes that would be a companion to the febrile infant care process model. But I'll tell you the long and the short of it. Herpes happens in the early neonatal period, usually within the first 3 weeks of birth. So, the times that I look for herpes are if a febrile infant comes in with a seizure, a febrile infant comes in with abnormal CSF, or a febrile infant comes in with skin lesions. Those are easy. Those are no-brainers for me. I can do the herpes testing and get the acyclovir going. Any one of you can do the same. That will account for 2/3 of all herpes. The 1/3, which is a nightmare and a killer of these infants, is what we call disseminated herpes with no skin lesions. So they have normal spinal fluid, no skin lesions, but it's in their blood. These babies come in as febrile infants, and they're really hard to recognize. And so what I do on all infants younger than 28 days is I send an AST and an ALT. And the liver function tests on infants with disseminated herpes are usually quite abnormal, in the hundreds to the thousands. And the AST seems to be more elevated than the ALT. So I send AST and ALT. If those are abnormal and the baby is 28 days or younger, I'm going to start acyclovir. If those are normal, I'm going to go through my normal febrile infant protocol, and now it's going to be 24 hours later. And if my bacterial cultures are negative and my viral testing is negative and my baby looks okay, then I'm fine, no problem. But if my baby looks sick, I'm going to do the workup for herpes and try to figure out if that's herpes. And you say, gosh, 24 hours has passed, is that going to be a problem? And it could be a problem. But we know that the average time of delay for the administration of acyclovir in the United States is 6 days. If I can get that down to 24 hours, I think I'm doing pretty well. And I'd like to try that strategy rather than giving acyclovir for every single febrile infant that comes in, because I think it's really unnecessary. We know that the rate of herpes in our population, I'm working with Russ Oskethorpe on this, is about 0.1% of the febrile infants that are evaluated, whereas about 12% of febrile infants have serious bacterial infection. So it's a huge order of magnitude difference, and I'd rather not give acyclovir to all of those babies. Kind of a long answer, but I hope I answered your question. One more for you, and that's it. I only do a chest x-ray on febrile infants in respiratory distress. And if I think that that respiratory distress is not due to typical bronchiolitis. Okay, thank you.